Hello, my name is Jen Weaver, and today I am going to be talking about translating assessments into clinical practice. Specifically, I'll use an example using the Coma Recovery Scale-Revised. We have many sources of information that keep us up to date on the newest innovations. This can include some of our premier journals and conferences are ways that we stay up to date. But how do we take this information that we've read about or heard about at a conference and bring it back to our clinical practice? How do we enable the information to inform our practice, our clinical reasoning, and how do we share this information with our clients and their families? In this photo, you can see the gap that exists between evidence-based knowledge and trying to implement new innovations into practice. From the literature, we know that this gap in bringing knowledge into practice can exist for up to 17 years from the time when we know that something works. For those of you that are not as familiar with the Coma Recovery Scale Revised, this is the administration scoring manual. However, we need to create better ways to bring information that is known from research to the rehabilitation practitioners in clinical practice. Many rehabilitation assessments produce ordinal scores. When we derive scores from assessments, we may even have change indices, which tell us when a change between two assessments is beyond measurement error, indicating progress, either improvement or decline, that's beyond measurement error. As researchers, we have been early adopters of the Roche measurement theory, which is a method that enables us to transform these ordinal scores into equal interval measures so we can make better inferences about not only the direction of our client's change, but the magnitude of that change. So, how do we ensure that our assessments produce reliable and valid results that are meaningful to rehabilitation practitioners, our clients, and their families? What do we need to implement new measurement innovations into clinical practice? This is where we can leverage implementation science. Implementation science studies the methods and identifies how well those methods work in order to put to use and integrate new information into the clinical setting. So today I'm going to talk about the need for and adoption of the recovery ruler in post-acute care for patients with disorders of consciousness. Disorders of consciousness occurs after a severe brain injury. A patient may be in a coma and transition to an unresponsive wakefulness syndrome or vegetative state. And they may also transition to the minimally conscious state. As practitioners, we look for our patients, our clients, to emerge from this minimally conscious state. A systematic review indicated that clinicians should use standardized neurobehavioral assessments. However, interviews with care partners indicated that they wanted more clinical information and that they were not receiving assessment result information. However, it is standard practice at many post acute care settings to administer the Coma Recovery Scale Revised. Here are the recommendations from our Disorders of Consciousness practice guidelines. A standardized assessment should be used, and we should use that standardized assessment in a serial manner so that we can improve our diagnosis and also describe recovery of consciousness. To describe the Coma Recovery Scale Revised a little bit more, there's 6 subscales about communication, verbal, motor performance, the patient's arousal, their visual, and auditory information. However, as you can see, these subscales are scored either 0 to 2 or 0 to 6. These ordinal scales cannot describe magnitude of change. And when we attempt to infer this information, we may misinfer the patient's progress. A 1-point change across that total ordinal score is not in equal intervals. Therefore, it is difficult to interpret change and difficult to explain this change to the patient's family. A 2 on the communication subscale indicates that the patient is likely emerging from the minimally conscious state, whereas a 2 on the motor subscale indicates that a patient is likely in the unresponsive wakefulness syndrome. Two very different diagnostic types. So some preliminary work that our team has done is that we have used the CRSR and transformed these ordinal scores into an equal interval scale using Roche analysis. Roche analysis produces what's called a key form. And a key form just shows the rating scale categories for each of the subscales along the equal interval ruler that can go from 0 to 100. We use this key form and co-designed it with family care partners and rehabilitation practitioners so that it was a tool that could be used in clinical practice. Our team leveraged the patient-centered measurement principles to generate meaningful change anchors for disorders of consciousness assessment. We felt that these principles could be leveraged to develop tools for existing assessments like the Coma Recovery Scale-Revised so that we can be more transparent with our clinical data in a comprehensible and timely manner. In terms of how this study that I'm going to be describing, it was informed by the knowledge to action framework. For example, some of our early work, we used the knowledge creation funnel in the middle when we were conducting the Roche analysis of the Coma Recovery Scale Revised. And we conducted a needs assessment through interviews and ethnographic observations to better understand what was happening in everyday clinical practice. We also conducted interviews with care partners and learned for those who received information about clinical data or assessments, they described how it helped them realize whether their person was improving, staying the same, or declining. Once we had the key form from the Roche analysis and an understanding of current clinical practice from our knowledge inquiry and synthesis, we were able to co-create the Recovery Ruler, a tool that visualizes the Coma Recovery Scale-Revised assessment result information, and it was co-created by practitioners and care partners. We believe that this element of co-creation and engaging relevant parties is essential for implementation science. This was one of our initial prototypes that was designed by incorporating a Roche keyform on the top half with 6 care partners and 8 rehabilitation practitioners from a variety of clinical settings. To provide a brief orientation to this key form, on your left side, you see a darker gray-blue where the CRSR domain scores relate to the unresponsive wakefulness syndrome. And as we move to the right side of the ruler, people are improving and getting closer to emerging from that minimally conscious state. What's a critical takeaway for practitioners and families is that as you see that 2 on communication indicates a much higher level of person ability level. So if you look down to the equal interval ruler, the 2 is in between 80 and 90 units. However, the 2 for the motor subscale is in between the 40 and 50 units, indicating that the person has much less ability and is likely in either the unresponsive wakefulness syndrome or minimally conscious state. We can see how each of the rating scale categories on each of the subscales, how they align with the 0 to 23 total ordinal raw score, as well as how they align to the 0 to 100 unit equal interval measure. These measures on the 0 to 100 unit scale enable us to compare change because the difference between a 0 and a 10 equates to the same amount as the difference between a 70 and an 80, which is not true for our ordinal raw scores. So here you can see when somebody uses a scale, and let's say a person reflects a 1 on communication, we actually show the range of the person's ability when they receive a score of a 1 on communication or a 1 on motor. When somebody receives a score on a subscale, that score truly reflects a range of person ability level based on how the item is administered. So for a pilot study that we conducted, we aim to examine the reach, adoption, and implementation of the recovery ruler across 4 clinical sites with specialty disorders of consciousness programs. In our first aim, we aim to tailor the recovery ruler for the 4 clinical sites, following the knowledge to action framework. Then we examine the reach, adoption, and implementation. And at the end of the study, we identified barriers and facilitators to adopting the recovery ruler. In AIM 1, we conducted focus groups and usability testing with practitioners from each clinical site. Our team had an instructional designer so that they could produce different iterative prototypes based on feedback received in each focus group. Because each site was able to tailor their own recovery ruler, it was mostly the modules that you see at the bottom where most of the changes occurred. Some sites had a notes text box. Some sites wanted to include that response range that I showed for each of the CRSR subscales. And some sites wanted to include the total raw score or the total um, measure score on the 0 to 100 unit. When we conducted our 6-month prospective observational study about the use of the recovery ruler, we had 26 practitioners participate in the study across the 4 clinical sites. They received 12 weekly online surveys followed by 3 monthly surveys. In those surveys, they answered a question as to whether they administered the Coma Recovery Scale-Revised. And if they answered yes to that question, we also asked them whether they included the recovery ruler when they administer the Coma Recovery Scale-Revised. Therefore, we were able to identify how many CRSRs were administered and the number of times that the practitioner used the recovery ruler across this 6-month observational study. At each of the sites, we also know how many practitioners are trained in administering, scoring, and interpreting the Coma Recovery Scale-Revised. We were able to recruit and consent 41% of these eligible practitioners to participate in the study. Of these practitioners, 92% of them reported adopting the recovery ruler at least once. In terms of sustaining the adoption of the recovery ruler across the 6-month study period, practitioners reported using it approximately 41% of the time. Therefore, at the end of this observational study, we conducted interviews with practitioners and organizational leaders at each clinical site. We wanted to know why people chose to adopt the recovery ruler, what made them continue to use the recovery ruler, and for those practitioners who did not participate in the observational study, we asked them whether they saw the recovery ruler being used, whether they tried it, and things of that nature. What we really learned from these interviews is that while barriers do exist, the practitioners really would have preferred to have the recovery ruler embedded in the electronic healthcare record. The paper versions being tested for adoption continue to be in use today after the 6-month adoption period. However, we also learned that practitioners would use the recovery ruler when family was at the bedside, which likely explains why practitioners only utilize the recovery ruler 41% of the time. The practitioners felt like it was the most useful when they were training practitioners in using the Coma Recovery Scale-Revised, as well as when family were present to describe the scores that their person achieved. So that recovery ruler, it was often utilized when the family was present. 2 sites are currently incorporating this tool into their electronic healthcare record. However, In the future, we plan to map the barriers and facilitators that were identified in the interviews to implementation strategies, because in a future study, we would like to test the implementation strategies to understand when and why the recovery ruler would sustain implementation across clinical practice. Now, each study is not without a study team, so although I presented this work today, I want to highlight other co-authors and mentors for this study today. So you'll see them on the following slides. I would also like to acknowledge that the funding for this work was provided by the American Occupational Therapy Foundation, and the funding to examine the diagnostic cut points on the recovery ruler was provided by the Department of Defense. Funding for the work that explored the family care partners' perceptions was provided by the American Institute for Research Foundation with support from the Robert Wood Johnson Foundation, and that was provided to Dr. Christina Papadimitriou and Dr. Trudy Mallinson. Thank you so much for your time today.